A pleasant good morning to all. Dr. M.L. Sorankar sir, Dr. Achal Gulati, Dr. N.D. Soni, Dr. Jaiswal, my senior colleagues, my friends and residents. Today we have all gathered here to speak on a clinical combined round from the Department of HPB Surgery and Liver Transplantation, Taming the Silent Storm, an uncontrolled hypertension in a young female. So I am standing here in front of you on behalf of the Department of HPB Surgery and Liver Transplantation and on behalf of my colleagues Dr. Devendra and Dr. Anil Kumar Gupta. The department was established in the year 2018. We started an MCH HPB surgical course in 2022. We are one of the only 4 institutes in the country which has got MCH HPB surgery. 2 batches have passed till now. We have got 1 full-time professor and 2 assistant professors in the department. The faculty participates in various CMEs and conferences with invited lectures in most of the national conferences of importance in the country, which includes Indian Society of Organ Transplantation, Indian Association of Surgical Gastroenterology, Indian Chapter of International Hepato Pancreato Biliary Association. Here fortunately I am the secretary-elect recently of this association, Liver Transplant Society of India, and many such other societies where we participate as invited faculty. We also participate in various international conferences where we represent Mahatma Gandhi Institute, be it at Singapore, the tripartite meeting of HPB surgery between Singapore, Malaysia and India, be it the Asia Pacific HPB surgery, and the recently concluded British Transplant Congress Society, where we had a good exchange of ideas between the 2 countries, where the United Kingdom needs more and more of living donor liver transplant of experience, which India is a world leader now, and India needs to increase the deceased donor transplantation. Coming to the conferences and the seminars and the workshops conducted by the department, we do train not only our own residents, but we also give training to various other residents from the state of Rajasthan and various faculties, practicing surgeons across the country in cadaver organ retrieval practices. The advantages here by this course is one of the medical college, Jhalawar Medical College, was able to perform organ retrieval after 2 of their faculty had come here to our institute and learned the organ retrieval process. This year we had invited an international faculty, Dr. Manisekhar from Malaysia, again to demonstrate an organ retrieval cadaver course in February 2026. Apart from the organ retrieval, we also have liver resection techniques, vascular anastomosis being given training on animal model and animal tissues. We conducted various national conferences over the last 1.5 to 2 years, where we had the Liver Summit and the IHPBA midterm meeting in September 2024. We also conducted international level liver transplantation session in Indian Society of Organ Transplantation last year, and this year IHPBA India in association with Mahatma Gandhi Hospital has conducted a national conference at Jaipur. Here we had more than 700 participations, where this summit was eventually featured, which is a global summit of HPB surgery, featured in various newsletters of the country. Our consultants also received traveling fellowships. Dr. Vinay and Anand both were invited and received a traveling fellowship to Seoul to gather more and understand more about their liver transplant practices. One of my anesthesia colleague, Dr. Kaushal Baghel, will be again traveling this year to Seoul on a traveling fellowship. Not only our consultants travel abroad, but we also now generate interest in various specialities and various candidates who are interested in coming to our department, either to visit or to take up fellowship in our department. So we had a resident from Nepal doing MCH surgical gastro who came to us and spent 3 months at our institute to learn about liver transplantation, and we now have a practicing surgeon from India who is doing fellowship in liver transplantation, who started just a month ago. Most important is, it is not only the consultant, but it is the residents who come out of this center. How and what do they perform? So most of our candidates, be it they are doing MCH surgical gastro or MCH HPB surgery, they have had presentations in national and international Hepato-Pancreato-Biliary Association and Liver Transplant Association. Personally, I am very proud that most of these, interestingly, are surgical gastro residents who trained and passed out as an MCH surgical gastro, now are actually practicing and heading a liver transplant program. And recently, some of our colleagues who have passed out have performed living donor liver transplantation just a month ago by the virtue of practicing and learning the nuances, being with us for the last 3 years. So these are the other residents again who have presented liver transplantation related various presentations and have received award in ILTS, also received award at the APASL, which is again an international meeting. The current batch again has presented at the Liver Transplant Society meeting in Singapore last year, and one of our resident who is going to present today had received an award for our research work done at Mahatma Gandhi Institute in the recently concluded IHPBA Indian annual chapter meeting in Jaipur 2026. Some of our anesthesia colleagues who have again passed out and have joined us as consultant presented their research work in liver transplantation and have also been awarded papers, mentor and mentee awards and best poster prizes as well. We have also had various national faculties visiting our department. The interest which we have generated in this department over the last 3 years has made Mahatma Gandhi recognized in the national forum as well as international forum in the field of HPB surgery, in the field of liver transplantation and HPB oncology. Here in this photograph we are seeing a doyen of HPB oncosurgery, Dr. Palipu Jagannath, who is from Tata Memorial Hospital, and Dr. Rajiv Joshi from Mumbai, who were very keen to visit our department and collaborate further for research at our institute. This is Dr. Rajiv Jalan from United Kingdom again, who had visited and was very happy and pleased to see the liver transplantation program being performed here on a regular basis. Apart from this, the department has had numerous publications which is in the range of 20 plus. We would also like to mention that contrary to the belief, we do lot of other surgeries apart from liver transplantation. We do living donor liver transplantation, robotic donor hepatectomies, but apart from that, we do pancreatic surgeries, not just limited to Whipple's, HPB cancer surgeries, gallbladder cancer surgeries, pancreatic cancer surgeries. We are now a large referral center for bile duct injuries, and we also help lot of our ancillary departments in the cases where they have got retroperitoneal large masses, IVC leiomyosarcoma, adrenal tumors, where we do help in the area of the operation. In liver transplantation, fortunately, Mahatma Gandhi Hospital is the largest center in the state of Rajasthan, and with multiple pioneering milestones being achieved at MGUH Hospital, where we did the first living donor liver transplantation, first liver transplantation for HCC, first pediatric transplant, first combined liver and kidney transplant, first dual lobe liver transplant, and fortunately we were the first center to perform a robotic donor hepatectomy in the state of Rajasthan. Our OPD has again increased over the last 3 years, so as the admissions as shown in these bar graphs. The operative records, as I said, we also perform liver resections, biliary surgery, pancreatic and other GI and miscellaneous surgeries. This includes major hepatectomy for cholangiocarcinomas, HCC, CA gallbladders, choledochal cyst excision, cholangiocarcinoma of the bile ducts, pancreatic cancer, body and tail, pancreatic neuroendocrine tumor, cystic neoplasm of the pancreas. We also do, as I said, IVC tumors, retroperitoneal masses. Some of the cases where bowel resection is required, we again go ahead and perform colectomies, splenectomies, and linorenal or splenorenal shunt surgeries as well. Again, the surgeries have increased over the last 3 years period. Looking at our liver transplant volume, Over the last 4 years, there has been a significant rise and a steady rise in the number of transplantation being performed. We had recently completed 150 liver transplants, and we had celebrated that. Today we have finished 168 liver transplantation with a very good success rate comparable to any other international centers as well. Nothing can be achieved without a major team, so this is a large teamwork which is responsible for the success of our liver transplant program. During the last 1 year, we have tried to push our envelope significantly, where we did a major IVC leosarcoma operation, whereby we did replacement of the inferior vena cava and hepatic venous reimplantation, which is one of the rare cases performed in this country. We did ABO, first ABO incompatible liver transplantation, large retroperitoneal tumors, and in this year, last 3 months, we have done all our last 12 donors. We have done robotic donor hepatectomy. This is just a short video to show how a robotic donor hepatectomy can change the scenario. These are the clips being applied on the small hepatic veins joining the inferior vena cava. Robotic surgery does give us good magnification, but at the same time, we operate in the field and the area which is small, narrow, and you need to be careful with the anatomy. This is the portal vein now being dissected. Here also we need to be careful that without damaging the portal vein, you need to perform the dissection. There is a small caudate vein branch which is going from the portal vein into the caudate lobe of the liver, which is taken between the sutures. The right portal vein is now being looped. Once this is looped, we are now trying to separate the right hepatic artery with a proper dissection. That is the right hepatic artery being looped. We have applied the clamps on the right hepatic artery and the right portal vein to get the line of demarcation, which is evident by the injection of indocyanine green. Then we start the resection or transection as per the requirement. Part of it is done robotically. So as I said, we were the first hospital to perform a robotic donor hepatectomy in this part of the country. The institute's vision, under the leadership of Dr. ML Swarunkar and Dr. Vikas Swarunkar, the plan is to shift the whole surgical and the medical department together under a single roof as Center for Digestive Sciences, and we are hopeful to keep on pushing the envelope and achieve more. Today's CCR, I would like to say, it is a little bit of a deviation from our regular presentation of simple history taking and the differential diagnosis, because there are various departments who have contributed to today's case, and I would like to now invite my colleague Dr. Gautam to take over the presentation. Sorry, the Urology department who will come and take over for the presentation from here. Dr. Shahil, come.
Good morning, everyone. I am Dr. Shahil Shah from the Department of Urology. I would like to start with the case. The 25-year-old female patient, a college student by occupation, belonging to upper middle strata of socio-economic category, hailing from Savai Madhopur, presented to the OPD with chief complaints of episodic palpitations with sweating since 1 month and unintentional weight loss since 1 month. The patient was relatively asymptomatic since 1 month, and she started noticing episodic palpitations which were sudden in onset and intermittent in nature. Each episode lasted for about 10 to 15 minutes and was not related to exertion or postural changes. It got relieved spontaneously. Each episode was associated with profuse sweating and sensation of ghabrahat. She also complained of unintentional weight loss, which was significant, of around 4 to 4.5 kgs in the last 1 month. However, on further questioning, there was no history of syncope, chest pain or documented arrhythmias. There was no history of fever, loss of appetite, chronic diarrhea, tremors or heat intolerance. There was no history of headaches, visual disturbances or any other focal neurological deficit. There was no history of orthostatic dizziness, flushing or panic attacks. There was no history of hematuria, frothy urine or pedal edema, and there was no history of any drug use or medication history. In past history, there was no history of diabetes mellitus, bronchial asthma, pulmonary TB, or any other cardiac illnesses, and there was no history of any surgical intervention. There were no history of any similar complaints in the family, and in treatment history, there was a history of visiting a local physician with the same complaints, for which she was prescribed antihypertensive medications, but she did not consume those. In personal history, she has normal appetite and normal bowel and bladder habits. Her menstrual history is she attained menarche at the age of 12 years and has regular menstrual cycle of 28 days with menstruation for 3 days, and the flow is normal. She has no known allergies or addictions. Going through the examination of the patient was conscious, comfortable, cooperative, and well oriented to time, place, and person. Vitals revealed pulse of around 110 beats per minute and a blood pressure of 240 by 120 millimeters of mercury in the right arm in sitting position. On checking for orthostatic hypertension, the supine blood pressure was 240 by 120 and the standing was 200 by 110 millimeters of mercury. The respiratory rate was 14 per minute and the saturation was 99% on room air. The BMI of the patient was 20 kg per meter square and there was no pallor, clubbing, icterus, cyanosis, edema or lymphadenopathy. On per abdomen examination, on inspection there were no dilated or superficial veins or scars. There was no abdominal visible mass, and on palpation there was no local rise of temperature. There was no tenderness, no organomegaly, and no other lump was palpable. There was no evidence of ascites. The respiratory, cardiovascular, and central nervous system showed no abnormalities. We proceeded with blood investigations, which were all within normal limits except hemoglobin, which was 9.8 grams per deciliter, and mildly raised liver enzymes, where the SGOT was 63 and SGPT was 90. The thyroid function test, ECG, chest X-ray, and 2D echocardiography were done, which were all within normal limits. Furthermore, we ordered a triple phase CECT abdomen. Requested a triple phase CECT whole abdomen. In the axial section, we could see that there is a tumor that is identified. Soft tissue mass lesion is identified with mild heterogeneous enhancement, which is located in between the inferior vena cava and the aorta. It is bound anteriorly by the portal vein and posteriorly by the vertebral body. Looking at the coronal section, we can see the tumor is slightly behind or posterior to that of the inferior vena cava and in between the inferior vena cava and the aorta. In another coronal section, the tumor is seen to be just inferior to the liver parenchyma and superior to the left renal vein. The impression of this CECT whole abdomen is a well-defined soft tissue attenuation mass lesion with mild heterogeneous enhancement is seen in retrocaval and aortocaval region at the level of D11 and D12 vertebral bodies, measuring about 4.7 into 3.8 into 6.3 centimeters in size. No calcification or fatty attenuation is seen in the lesion. No IVC, aortic, liver or vertebral invasion is seen, and the lesion abuts the body of the right adrenal gland with loss of intervening fat planes. The IVC is displayed towards the right side and anteriorly. To summarize, a 25-year-old female presents with 1 month history of episodic palpitations associated with profuse sweating and unintentional weight loss. The differential diagnosis at this point can be pheochromocytoma, hyperthyroidism, cardiac arrhythmia, or panic disorders. But when we add to that the clinical examination that we did, she was noted to have high blood pressure, while the abdominal and other systemic examinations were unremarkable. The differentials can be changed to pheochromocytoma, paraganglioma, and hyperthyroidism. Now, when we add the lab investigations and the CT scan imaging findings, the differentials can just be paraganglioma and pheochromocytoma. I would like to invite Dr. Utkarsh to take us forward.
Thank you, Dr. Shahil, for introducing the case. A very good morning to everyone. I am Dr. Utkarsh Balani, third year DM Endocrine Resident, and I will be taking the case further to discuss the approach and management in this case. So, to recapitulate, we have a 25-year-old female with a 1 month history of paroxysmal sweating, palpitations, hypertension, and weight loss. Imaging had already shown a retrocaval and aortocaval mass, raising suspicion of paraganglioma. So, from the endocrine perspective, the key questions were whether this was a functional lesion, and if it was, then whether the disease was unifocal, multifocal, or metastatic, as around 10 to 20% of cases can present metastasis. So to biochemically confirm this patient, we have a list of investigations. There are plasma-based investigations and there are 24 urine-based investigations. As per the guidelines, we could go ahead with any of these investigations, but in clinical practice, we prefer the plasma investigations as they are much easier to do and also does not require 24-hour urine collection. So in this patient also, we went ahead and did the plasma sample. Now, out of these three, we preferred going for either normetanephrines or metanephrines. To decide between these two, we had to know a bit about the catecholamine pathway. The catecholamines are made, the substrate is tyrosine. From tyrosine undergoes multiple enzymatic reactions to form dopamine. From dopamine, norepinephrine is generated, and from that, epinephrine is made. These dopamine, norepinephrine, and epinephrine are the catecholamines. These are then converted to the respective metabolites such as 3-methoxytyramine, normetanephrine, and metanephrine by the enzyme carboxymethyltransferase. Another important enzyme that we have here is the PNMT. This particular enzyme it has a special characteristic that it is only and only present in the adrenal medulla, and it requires cortisol-rich environment for its activation.
That was the reason I thought of including the cortex in the region, because if the cortex is not there, if the cortisol is not there, norepinephrine will not be converted into epinephrine.
The enzymatic activation won't be there if there is no cortisol.
Will be required.
So the pheochromocytomas, that is the one arising from the adrenals, since they have a good amount of PNMT activity, they can produce both norepinephrine and epinephrine. Whereas an extraadrenal paraganglioma does not have this particular enzyme. So the norepinephrine is not converted to epinephrine, and thus in these patients we have to check for plasma-free normetanephrines, as in that was in our case. So our case had an extraadrenal lesion. So in this patient we went ahead and did the normetanephrine levels in this. So we requested a plasma-free normetanephrine levels, which came out to be more than 2000 picogram per ml. Normal value is less than 180. This was a significant rise in the value, giving a strong evidence of a functional catecholamine tumor. So, integrating the imaging findings and the biochemical evidence, we concluded that this patient had a functional sympathetic paraganglioma in the retrocaval and aortocaval region. So now for the audience, what exactly are these paragangliomas or pheochromocytomas? So these are collectively called as PPGL, that stands for pheochromocytomas and paragangliomas. These are rare, often genetic neuroendocrine tumors originating from the chromaffin cells. The chromaffin cells is within the adrenal, they are called as pheochromocytoma, whereas a paraganglioma is a tumor arising from the extraadrenal chromaffin tissue. In our case, we could see that the patient had a retrocaval aortocaval lesion. This was probably a paraganglioma because it was outside the adrenal. These are the various locations of the parasympathetic and the sympathetic paragangliomas in our body. Clinically, these tumors often present with catecholamine-related paroxysmal symptoms such as hypertension, headache, palpitation, sweating, tremors, and anxiety, out of which hypertension is mainly due to alpha-1 mediated vasoconstriction. So now we have proven that the patient had a biochemically confirmed paraganglioma. What could be the next step? So as per the guidelines, the next step should be functional imaging of these lesions as well as genetic evaluation given the young age of the patient. Now functional imaging was needed to further characterize the lesion, whether it was a SSTR to produce expressing a tumor, and to assess whether the disease was localized or associated with any multifocality or metastasis. At the same time, given the young age of the patient presenting with a paraganglioma, genetic testing was also required. So we went ahead and we did both the tests. So we requested a gallium-68 Dotanok PET CT in this patient, which showed an SSTR2 expressing heterogeneously enhancing mass in the upper aortocaval, retrocaval, and retroperitoneal region. The findings favored paraganglioma, and there was no evidence of distant metastatic disease in this patient. So overall, this supported the diagnosis of a localized retrocaval para-aortic paraganglioma. Coming to genetic testing, this also holds very important in this particular case, as this was a young female presenting with paraganglioma. Around 30 to 40% of patients can have a germline pathogenic variant, out of which SDHB and SDHD mutations are the most common. In addition, we also required syndromic associations have to be ruled out. Now, identifying a mutation is not only important for the patient, for its prognosis, for further planning of the patient, and also for deciding whether she would respond to some targeted therapy, but it is also important for the family members, as most of these conditions are inherited in an autosomal dominant manner. So given the indications, we ordered clinical exome sequencing of this patient, and the sample was sent. So till now, just to summarize whatever we have gone through, requested. Yes. Just to summarize till now, so we have a 25-year-old female presenting with a single well-localized functional extraadrenal paraganglioma, confirmed clinically, biochemically, and on functional imaging, with genetic testing samples sent as a part of overall workup. So the next step was to plan definitive management, and for that a multidisciplinary team meeting was held, which included departments of Endocrinology, HV surgery and liver transplant, Urology and Anesthesiology. Now, since this was a single, well-localized functional paraganglioma without any distant metastasis, the preferred treatment was surgical excision. Once the decision was made, we went ahead and we did the pre-operative preparations and pre-anesthetic checkups. Now, coming to pre-operative preparations, now this is a very critical step in any functional paraganglioma. The aim is to prevent any perioperative catecholamine surge, to reduce any intraoperative hemodynamic instabilities, and also to avoid post-operative hypotension, which is very important. So the sequence of treatment is very important. We start first with the alpha blockade first, because the dominant hemodynamic effect is because of alpha 1 mediated vasoconstriction. Also, along with that, we advise the patient to take extra salt and fluid loading. If you all remember, for any hypertensive patient, we always suggest to take a low salt intake. This is one of the cases where we actually tell the patient to increase the salt intake, because increasing salt intake and increasing fluid intake will increase the expansion of it will cause volume expansion. So since these patients are in a chronic volume contracted state, so we need to give extra salt and extra fluid to increase the volume, so that in the post-operative period the patient does not land up in hypotension. So after starting both the alpha blockade and the salt and fluid, keeping the targets of blood pressure of less than 130/80 in seated or supine position and more than 90 in standing position, we titrate a dose of alpha blockade. We might underwent a situation where we are not able to increase the alpha blockade further because there is a further orthostatic fall. In such cases, we can even add the patient a calcium channel blocker. Once an adequate alpha blocker is achieved, only after that we add a beta blocker to control the tachycardia. So a question for the audience, especially the medicine residents, why can't we start with the beta blockers first and alpha blockers later? Exactly. So if we start with the beta blockers first, that can lead to an unopposed alpha stimulation, and that can lead to precipitated crisis in the form of uncontrolled hypertension. So in our patient also, I would like to highlight a few important points in this patient. This is the whole graph of the patient as with us. We can see that it took about 18 days of pre-operative management for this patient before she finally underwent surgery. Important point was that when she presented to us, initially she was normotensive. She had a BP of 93/65. So a normotension does not mean that the tumor is non-functional or non-secretory. It can be present in any case where the catecholamine surge is not present. During the catecholamine surge, the BP can rise, but in between the episodes, patient can present a normotension. So another important point is, like, if the patient is having normotension, that does not mean that she won't require blockade. Irrespective of what the BP is, the patient will require a blockade therapy before undergoing surgery, as she is bound to have intermittent spikes during intraoperative period. So as we can see, we first started the patient with alpha blockade therapy, and also we started the patient on extra salt and oral fluids. Upon increasing the volume expansion, the BP improved. Now, keeping in target of seated supine BP of less than 130 and standing SBP of more than 90, we titrated a dose of alpha blockers. We even reached a stage where further titration could not be done as the patient was having significant orthostatic hypotension. So in this case, we added the patient a calcium channel blocker. Upon achieving adequate alpha blockade, then and only then we added a beta blocker to control the heart rate. And the beta blocker dose also titrated, keeping in mind a supine heart rate of 60 to 70 and a standing heart rate of 70 to 80. Once these targets were achieved, only then we referred the patient back to the surgical department. We also gave special instruction to surgical team that to give overnight 1 liter of normal saline pre-operatively on the night of the surgery. Another important thing I would like to note that you can see that the patient, even after giving definitive alpha blockade, she still had intermittent spikes in blood pressure. This is clinically very important, as whatever we are doing with this patient, the goal is to reduce the risk of intraoperative spikes in blood pressure, but we cannot completely eliminate it. So this was then conveyed to the surgical and the anesthetic team that while tumor handling, the patient will land up or might probably have some intraoperative spikes in the blood pressure. Now, before calling the surgical resident, I would also like to emphasize on one more point, that the surgery is not the end of everything, as these tumors can have a chance of 15 to 20% recurrence over the next 10 to 15 years. Renal monitoring also is very important in these patients. Now I would like to call upon Dr. Gautam Mohan from Department of HV Surgery and Liver Transplant to take the case further.
Good morning everyone, I am Dr. Gautam, third year resident. Now to encapsulate, we have 25-year-old female with uncontrolled hypertension, evaluated with CT showing a 4 into 6 cm tumor located in the aorta cava and retrocaval position, and it was found to have a catecholamine excess. Dotanox scan further proved that this is a solitary functional paraganglioma with no metastasis. A multidisciplinary team decided surgical resection as the best management for this patient. As my colleague earlier mentioned, she was given alpha and beta blockade over a period of 2 weeks for optimization of blood pressure, and the anesthesia team was monitoring the patient in regular intervals, and she obtained PAC fitness for the surgery. It is time now to decide how to proceed with this case. We have a traditional open method and a minimally invasive surgery. The minimally invasive include laparoscopy as well as robotic surgery. Open surgery, though traditionally preferred, comes with a higher morbidity, increased blood loss, and it requires a larger incision like Mch incision or a hockey stick incision or a Mercedes-Benz incision, which is associated with the delayed recovery due to pain, and it does not offer any additional precision in the deep space. Secondly, laparoscopy. It has a significant limitation in the dexterity and precision, especially in the retrocaval region where fine vascular resection and dissection is critical. The instrument rigidity and the limited range of motion make it less ideal to work near IVC, and hence we needed an approach that combines precision, control and minimal invasiveness, which is where robotics stand out. The robotic approach offers several key advantages in this case. First, it provides a superior 3D visualization in the deep and narrow spaces like the retrocaval region. The wristed instruments also allow precise dissection around the IVC, ensuring better vascular control. At the same time, it remains minimally invasive, promoting faster recovery. Overall, the robotics offer the best balance of precision, safety and minimal invasiveness. For this case, our primary approach was robotic excision with a low threshold for conversion to open surgery if safety was compromised at any point. Given the tumor's proximity to the major vessels, our top priority was vascular preservation, particularly safeguarding the IVC and the major adjacent structures. The key step in our strategy was early vascular control. We ensured identification and control of the critical vessels, minimizing the risk of catastrophic bleeding and catecholamine surge. And our guiding principle throughout the procedure was dissect first, secure the vascular control and only proceed to handle the tumor, because this can lead to sudden catecholamine surge in this patient and result in hypertension. Ultimately, our goal was very clear: to achieve a safe and complete resection without vascular injury. So this is a diagrammatic representation of the tumor and its close proximity to the structures. The one marked in yellow is the tumor, and lateral to it is the IVC, which is the major vessel which carries the blood to the heart, and it is pushed anteriorly and laterally. Next is the portal vein, that is along with the common hepatic artery included in the hepatic duodenal ligament that lies anterior to our tumor. This is the left renal vein, which is located inferior to the tumor, and aorta, which is located medially. To compare this with the CT image, this is the tumor and we have laterally the IVC and medially the aorta. This case presented multi-layers of complexity. First, the anatomical challenge. The tumor was located in the retrocaval and aortocaval region, which is one of the most difficult area to access surgically. Secondly, the vascular challenge. The lesion was abetting and displacing the inferior vena cava, significantly increasing the risk of major vascular injury during the dissection. You can see IVC located laterally, aorta, portal vein anteriorly and aorta medially. Third challenge is the physiological risk. Being a functional tumor, it posed a constant threat of intraoperative blood pressure surges, especially during manipulation. And next is the spatial limitation, that is working in a confined retroperitoneal space surrounded by the critical structures. and the robotic surgery in such high vascular zone demand extra precision and control. So the core challenge in this case was striking right balance between the precise meticulous dissection and tight hemodynamic control. So this was the port placement in our patient. To start with the procedure, after docking the robotic arms, first we took control of the inflow to the liver by looping the hepatoduodenal structure, that is with the blue sling. Now you can see the tumor with the aorta seen as the medial margin of the tumor. After gentle traction was applied to the SDL tissue. Fibrofatty tissue of the tumor was carefully dissected. Now what you see in the blue color is the IVC, which is pushed laterally and lying in front of the tumor. Dissection of the fibrofatty tissue over the tumor was continued. After dissecting the margin between the IVC and the tumor, what we can see in blue color is the suprarenal IVC, which is being looped with an umbilical tape, as you can see, and it was retracted, which helped us in exposing the deep plane between the tumor and the IVC. Multiple veins draining the tumor to the IVC were noted. They were carefully dissected and divided either by energy source or by using a clipping of the vessels. Once the lateral dissection was completed, we further proceeded with the inferior dissection of the tumor, that is dissecting the tumor between the tumor and the left renal vein. We can clearly see now the left renal vein being retracted down with a suction catheter here, that is helping us in dissecting the tumor plane. The feeder vessels were identified and clipped and divided. The major challenge for the surgeon was to identify the vessels draining the tumor. In this case, we encountered multiple such vessels. This is important because early ligation of veins draining the paraganglioma reduces the intraoperative surge of catecholamines. Dissection was further continued in deeper planes. As you can see, this is one of the largest vein which we encountered during the dissection, and it was seen draining to the IVC. Careful dissection was carried around the vein. You can see the vein marked in blue draining to the IVC. This was clipped and divided. Similarly, the tumors was dissected superiorly. During the dissection phase, we encountered few episodes of hypertension, that is catecholamine surge, for which the procedure was paused until the BP was controlled by the anesthesia team. You can see the dissection is being continued all around the tumor, and now you can see the tumor completely coming out between the IVC and the aorta, and the posterior attachment of the tumor is being released. The tumor is now completely freed and it is delivered out in an endobag. Now you can see the tumor bed. Medially is the IVC, inferiorly is the left renal vein, medially aorta, anteriorly the portal vein and the hepatic artery and bile duct. Hemostasis was achieved and the drain was placed. The tumor was retrieved out through one of the port side, which was increased in length, and the tumor excised was measuring almost around 5 into 5 centimeter, and this is how the tumor was oriented with respect to the major vessels. The specimen was sent for histopathological examination. This picture shows the port side. The arrow shows the incision through which the specimen was extracted out. Let's discuss the postoperative recovery. It was smooth and stable. We were able to extubate the patient on table and she had a good respiratory recovery. Importantly, there was no episode of any hemodynamic instability during the immediate postoperative phases, and she was shifted to ICU immediately after the surgery, and she was maintaining a normal BP throughout. The recovery progressed well. She was started with oral feeds on post-op day 1. She was ambulated and mobilized. There was no episodes of any postoperative bleeding events or vascular complications, and additionally the electrolytes and renal parameters remained stable throughout. The key takeaway here is that despite a high risk nature of the surgery, the patient had an uneventful and smooth postoperative recovery. As I mentioned, we encountered with the catecholamine surge in the surgery. Now I call upon Dr. Sampragyee to discuss regarding the anesthetic challenges and management in this case.
Thank you, Dr. Gautam. Good morning, everybody. I'm Dr. Sampragyee Singh Tomar from Department of Anesthesia. We will now proceed to the intraoperative anesthesia management. Following exhaustive pre-anesthetic evaluation, meticulous optimization, and multidisciplinary planning, the patient was taken up for robot-assisted paraganglioma excision. For preemptive analgesia, 200 micrograms of intrathecal morphine was administered prior to induction of general anesthesia. Given the absence of significant clinical concerns, induction of general anesthesia was achieved using fentanyl, propofol, rocuronium for muscle relaxation to facilitate airway management and ventilation. Hemodynamics remained stable during induction with no significant fluctuations. In addition to standard anesthesia monitoring, invasive arterial blood pressure monitoring and central venous access via triple lumen catheter was established in anticipation of significant hemodynamic fluctuations. During the initial phase of surgery, however, the patient remained hemodynamically stable. In anticipation of a catecholamine surge associated with tumor manipulation, a proactive preparedness-based approach was adopted. Target controlled infusion of propofol along with dexmedetomidine infusion was initiated to attenuate sympathetic outflow. Vasoactive infusions like nitroglycerine, labetalol, and noradrenaline were prepared and kept readily available, ensuring the ability for rapid titration and prompt intervention during hypertensive episodes. Approximately 1 hour into dissection, upon nearing the tumor, blood pressure acutely escalated with systolic values rising to 280 to 300 mmHg. Given the ongoing hemodynamic fluctuations, a controlled, intermittent, start-stop dissection strategy was adopted to allow stabilization between tumor manipulation. Rapid escalation and titration of vasoactive infusions were undertaken to achieve prompt control of severe hypertension. This graph here depicts the intraoperative blood pressure variability and highlights the sequential use of different vasoactive infusions for hemodynamic control. As the blood pressure was still increasing, dexmedetomidine infusion was immediately discontinued and transitioned to nitroglycerine infusion to achieve rapid, titratable blood pressure control. But due to ongoing blood pressure surges despite NTG, labetalol bolus followed by infusion was commenced, resulting in partial attenuation of hypertension. Despite partial response,
for gynae residents, obstetric residents, labetalol is the drug of choice for hypertension in eclampsia and severe preeclampsia.
Despite partial response, intermittent hypertensive spikes persisted, with systolic pressures ranging between 200 to 280 mmHg, indicating incomplete control given the magnitude of catecholamine release. Due to persistent hypertension, nitroglycerine was then replaced with sodium nitroprusside infusion, which provides potent, rapid, and balanced arterial and venous vasodilation, making it more effective in severe catecholamine-mediated hypertension. Although prolonged use of sodium nitroprusside is constrained by the risk of cyanide accumulation and subsequent toxicity, effective blood pressure control was ultimately achieved with a combination of sodium nitroprusside infusion, labetalol infusion, and intermittent boluses of labetalol. Following tumor excision, blood pressure normalized promptly. All antihypertensive infusions were tapered and discontinued, following which transient vasopressor support with noradrenaline was required due to a sudden drop in circulating catecholamine levels. The patient was then adequately reversed and extubated on table. Immediate post-operative neurological assessment was normal. Thank you. I would like to now call upon Dr. Neha Jain.
Good morning, everyone. I am Dr. Neha Jain from the Department of Oncopathology. So basically, the gross specimen was received in our department. It was an excised specimen of an encapsulated mass measuring 4.4 into 3.8 into 2.4 centimeter. The outer surface was smooth and partly covered by fat and soft tissue, and the cut surface was yellowish brown and friable. On microscopy, basically the procedure performed was robotic assisted excision of right paraganglioma. The tumor location was extraadrenal. The tumor size, as mentioned, was 4.4 into 3.8 into 2.4 centimeter. The histological diagnosis of paraganglioma was made. There was no capsular and peritumoral soft tissue invasion seen, and the tumor proliferative activity was low, that is 1 to 2 mitosis per 2 mm square. The resected soft tissue margin was free of tumor. So basically this is a 40x H&E image of a paraganglioma which shows the cells arranged in cell balance pattern. So the cells have abundant eosinophilic to amphiphilic granular cytoplasm with round to oval vesicular nuclei. So the final diagnosis of paraganglioma was made. Now I would like to call upon Dr. Gautam for further discussion. Thank you.
Thank you, Dr. Neha. To continue, this case resulted in an excellent clinical outcome. We achieved a complete tumor excision while successfully preserving the inferior vena cava with no major vascular injury. Throughout the postoperative period, the patient maintained stable hemodynamics, which is particularly significant given the functional nature of the tumor. The postoperative course was smooth with early recovery in ICU followed by early oral intake, mobilization, timely drain removal. Importantly, there were no postoperative complications or infections. The patient was discharged in a stable condition on postoperative 5 and notably did not require any antihypertensive medication thereafter, indicating an effective resolution of the catecholamine excess. At follow-up, the patient is doing well, comfortable and vitally stable with no residual symptoms. Given the functional nature of the tumor, our plan is to biochemically reassess with a plasma-free normetanephrine after 1 month to confirm the complete resolution of catecholamine excess. This will also serve as an early marker of any residual or recurrent disease. To continue with discussion, paraganglioma are the neuroendocrine tumors arising from the extraadrenal chromaffin cells. Broadly, they are classified into sympathetic and parasympathetic paragangliomas based on their origin and behavior. Sympathetic paraganglioma are located in the thorax, abdomen, retroperitoneum and are often functional, secreting catecholamines, and the patient presents with symptoms like hypertension. In contrast, the parasympathetic paraganglioma are usually found in the head and neck region. They are typically non-functional and often present as a mass rather than symptoms. About 60 to 70% mainly sympathetic are functional and 30 to 40% are non-functional. Overall, the tumor are rare with a prevalence of 2 to 8 million per year and 2 to 8 per case per million per year, and important aspect is the genetic association with which is up to 30 to 40% being hereditary, and associated gene mutation are SDH, VHL, RET and NF1. सर ये जेनेटिक टेस्ट कराया था सर, 1 महीने का रिपोर्ट का वेटिंग पीरियड है तो अभी आने वाला है. Additionally, around 10 to 20% can be multifocal, especially in the hereditary cases. Surgical resection remains the only curative treatment for localized paragangliomas. However, the resectability depends on multiple factors, particularly the tumor number, size, the factors like the degree of vascular involvement, especially the IVC and aorta, and the presence of any metastasis. In localized retroperitoneal lesion, R0 resection is achievable in approximately 70 to 90% of the cases, and in advancing expertise, minimally invasive and robotic approaches are increasingly feasible, but only in carefully and selected patients. On the other hand, an extensive vascular encasement or an unresectable metastatic disease are the major contraindication to this surgery. And importantly, adequate preoperative optimization, particularly with alpha and or with beta blockade, is absolutely essential to ensure a perioperative safety. Now, the paraganglioma may carry a recurrence risk of around 10 to 20%, which is higher in extraadrenal and hereditary cases. The risk of malignancy or metastatic disease is about 10 to 15%, particularly elevated in patients with SDSB mutations. Importantly, the recurrence can be very late, that can be up to 10 to 20 years after the initial treatment. Therefore, a lifelong surveillance is essential in this case. Follow-up include an annual biochemical monitoring with plasma-free metanephrines or normetaphrines, and in addition, periodic imaging with a CT or MRI that is either functional or non-functional recommended, especially in high-risk patients. Finally, the genetic testing play a crucial role, and it helps in guiding the surveillance intensity and long-term management. So the key message is long-term vigilance is critical even after an apparent successful resection. Coming to the literature, when we look at the existing literature, the robotic resection of a retroperitoneal paraganglioma remains extremely limited, confined to isolated case reports and a small case series. Importantly, the majority of these cases involve para-aortic or inter-aortocaval tumor. In contrast, true retrocaval paragangliomas are exceedingly rare, making our case anatomically unique. And available reports do suggest that with meticulous preoperative planning and appropriate expertise, robotic approaches can be feasible even in challenging anatomical locations. However, due to a very small number of documented cases, there are no standardized surgical approach. So in this context, to the best of our knowledge, our case may represent one of the first reported instance of a complete robotic resection of a large functional paraganglioma in a retrocaval aortocaval location. This highlights not only the rarity of the disease but also the expanding role of robotic surgery in complex vascular territories. This case highlights a few important lessons. Always maintain a high index of suspicion for a pheochromocytoma or a paraganglioma in a young patient with severe hypertension, and confirm the diagnosis with appropriate biochemical testing. Adequate preoperative optimization with alpha blockade and beta blockade is crucial for a safe surgery. Imaging play a key role in defining the anatomical roadmap, especially in relation to the major vascular structure. For surgical perspective, robotic resection is feasible in expert hands but require meticulous planning and precision. Equally important is the tight hemodynamic control achieved through close coordination with anesthesia. And finally, outcomes are best when managed with a multidisciplinary team approach. This is our surgical team. Now I call upon Dr. Devendra Chaudhary to conclude this session.
Good morning everyone, I am Dr. Devendra Chaudhary. I will be summarizing this session. So why this case stands out, we have discussed all these points already, the team has discussed. So two important points which stands out here is that this case emphasizes the importance of the interdepartmental discussions and the interdepartmental discussions to manage such kind of cases. And the second is the robotic resection. The MGUMST management had provided us with a world-class robotic program, and our department under the leadership of Dr. Nemish Mehta sir is now catering the patients who needs complex and advanced robotic surgery. What did we learn from this case? Two important points. One is what is the safe duration of the intraoperative hypertensive extremes. In the literature, there is no clearly defined safe duration. However, the brief intraoperative spikes can often be tolerated. Spikes beyond 10 to 15 minutes, they significantly increase end organ damage, which again depend on the magnitude of the blood pressure rise and patient comorbidities. And second is that the meticulous pre-operative evaluation, preparation and execution is important in managing these kinds of cases. So again, I would like to thank management of MGUMST, the CCR review committee, and our fellow department of Urology, Endocrinology and Anesthesiology for pre-operative and intraoperative optimization of the patient. Department of Radiodiagnosis and Department of Nuclear Medicine for correctly localizing and excluding the metastatic nature, and Department of Oncopathology for putting the final stamp on the diagnosis, and of course the patient and the family members. Thank you.